So we'll move on to the second talk on repurposing ivermectin by Dr. Panisadee Avirutnan from Mahidol University. Again, this paper came out just a few weeks ago, maybe 1 or 2 months ago, at Clinical Infectious Diseases. It's a trial that's been done in Bangkok, and I'll let Dr. Avirutnan tell you the rest of the story. Please take it away.
Thank you. Thanks, Professor Eong, for inviting me to a very interesting meeting and to join the discussion today. Let me share my slide. Actually, let me introduce a little bit of our work in the lab that has been going on. At CIRAD, actually, we focus mainly on, one of the focus in the lab is to search for dengue therapeutics. And because our team is so much interested in the NS1 protein, and so that would be also the important target. So we generate actually a lot of monoclonal antibodies against NS1 using different methods like mouse monoclonal, as well as human mouse chimera antibodies, as well as human monoclonal antibodies generated from our patients in the cohorts, which have been going on for many years. And in fact, another main area to search for dengue therapeutics is we focus on using repositioning strategy for dengue therapeutics. And we have recently developed an in vitro model, cell model, to test for those repurposed drugs, and then select, hopefully to be able to select the good candidates for going further for in vivo experiments, and then finally to the human trials. And in parallel, we also entertain an idea of developing a platform for future drug and vaccine testing in dengue endemic area, like in Thailand. So we are collaborating with Professor Durbin and Whitehead in the US, who successfully developed control human infection model for dengue in naive population in the US. And so hopefully that we can establish this platform in Thailand. It would be a very good infrastructure for further vaccine and as well as therapeutics development. So among several repurposed drugs, ivermectin is our main focus, of course. And so far we have 2 clinical trials. One efficacy trial in adults, of which the results of the trial just been out, and another trial PK/PD study in pediatric dengue patients as well. So ivermectin is actually a very safe drug, and it's been licensed for human use for more than 30 years, actually since 1987. And its safety has been assessed in over 7 trials, maybe 100 now. And since 1988, the single dose of ivermectin, which is around 150 to 200 microgram per kilogram, have been distributed by Merck donation program to treat onchocerciasis, and later expanding for lymphatic filariasis together with other drug combination. So anti-parasitic effects of ivermectin is that it binds irreversibly with high affinity to glutamate-gated chloride channel on nerve and muscle cells of the nematode, causing hyperpolarization, increased permeability of chloride ion, causing parasites to become paralysis and death. So a very high dose actually has been administered in healthy individuals performed by Gazo, which about like 10-fold higher than regular anti-parasitic dose. And he did not see any greater adverse event over the control group. The reason for very low toxicity and having good safety profile in humans is that the drug, the receptors for ivermectin in humans pretty much exclusively expressed in the central nervous system, and the drug does not cross blood-brain barrier. So, there were reports showing that the dose up to like 15 milligram per kilogram, like 70 times higher than regular prescribed dose, could see the toxicity in humans. The drug is fat soluble, very lipophilic. It binds strongly to some of the plasma proteins and also causing wide tissue distribution. So, for dengue, this is a very early these are early publications. They show that ivermectin binds to helicases, helicase domain of NS3, and therefore inhibiting virus replication. And another group of works show that ivermectin actually binds to host important protein, then prevent the interaction of important to NS5, and therefore preventing the protein getting into the nucleus, and therefore inhibit virus replication. And in that paper, they show that the drug worked for dengue serotype with quite reasonable micromolar single unit micromolar range of EC50. So recently there is a publication going more into the detail of the mechanism of how ivermectin inhibit nuclear translocation of host protein, and therefore affecting several other viral proteins, including dengue and some other flaviviruses. So without ivermectin, NS5 is actually recognized by important alpha-beta heterodimer, followed by nuclear transport and to induce affect host antiviral response. So with ivermectin, the drug actually binds to the ARM or alpha-rich armadillo domain of the importin alpha, and therefore preventing the heterodimerization of these complex. And also they also show that ivermectin can dissociate heterodimer of importin alpha and beta. And with that, so the virus protein cannot get into the nucleus, and so increase the antiviral response. And in that paper, they show also that ivermectin has a very high efficiency to inhibit West Nile virus, like in a very low micromolar range EC50, and they also expand the work by testing with the human peripheral blood mononuclear cells. And they found that not just dengue virus, but also ivermectin worked to inhibit Zika virus infection in human PBMC. And noticeably, the the EC50 in PBMC is quite higher than testing in the viral cells. So because ivermectin has been widely used as an anti-parasite therapy and with a good safety profile, it is relatively also inexpensive and can be administered orally. So it is that very suitable for administration even in limited healthcare resource settings like Thailand. So we decided to conduct a phase 2/3 clinical study to assess its efficacy against dengue virus infection in adult patients. So in the phase 2, the trial, in phase 2, the trial focused on virological endpoints and to find optimal dose of the ivermectin 2 days, single dose, once daily for 2 days or 3 days with higher dose than a regular parasitic infection. So it was like 400 microgram per kilogram. And the primary outcome for the phase 2 were area under the curve for viremia, from the start of the treatment until 48 of 72 hours, as well as time to viremia clear or NS1 clearance. And so after that, we then select only one arm and then went through the phase 3 trial to determine clinical efficacy, which are fever clearance and the proportion of patients who developed DHF. So for the phase 2 trial, a total of 116 patients were enrolled since February 2014 to October 2015. And we had 108 patients, including 36 for placebo, 38 for ivermectin 2 days, and 34 for ivermectin for 3 days were included for the analysis. And the planned sample size around 30 patients in phase 2 was based on the simulation model published by Cameron Simmons in this paper. And the treatment were expected to have about half a log reduction in viremia or NS1 clearance compared to the placebo. For the primary endpoints, actually finally were not met, and we do not, no difference in AUC viremia or time to viremia clearance. However, we observed that NS1 clearance time was shorter in 3 days ivermectin treatment, although not statistically significant. And interestingly, we observed fever clearance was significantly shorter in the ivermectin 3-day group compared to placebo. So after reviewing safety and efficacy for phase 3 with only 2 arms running through October 2015 to 2017 was begun with additional 130 patients, so 65 from placebo and 65 for the 3-day ivermectin group. And there were 3 patients were withdrawn and 1 excluded. So overall, a total of 105 and 101 patient 103 patients in the placebo and 100 patients in the ivermectin treatment group were included for the analysis. There were actually the target population or enrolled population were less than we previously planned. That is because some technical difficulties related to funding and slow enrollment rate during late off rainy season. So here are the results of the phase 3 baseline characteristics and laboratory results were similar in the two study groups, and there were no significant association between treatment allocation and any of the predefined clinical outcome, including fever clearance and proportion of patients who developed DHF. The significant difference between treatment and control groups that we observed were actually the proportion of undetectable NS1 at discharge, which were 49 for placebo and 72 for ivermectin group. And also we found NS1 antigenemia clearance time was shorter from 4 days versus 3 days in ivermectin treatment group. Kaplan-Meier plots show that NS1 antigenemia clearance was significant, shortened in ivermectin 3-day group, shown here. However, we do not observe significant difference in fever clearance and viremia clearance. So differences in dynamic changes of circulating and viremia and NS1 between treatment arms were analyzed by mixed model analysis. So only patients with at least 3 consecutive measurements were included. So of 178 patients, there were no difference in the pattern of viremia clearance here. And we also do subgroup analysis for the patients who were treated within 72 hours versus later than 72 hours as well. And we see no difference in viremia clearance. However, we did observe faster reduction of NS1 over time was found in ivermectin 3-day treatment group, and subgroup analysis also show faster NS1 in the 3-day ivermectin compared to placebo, but not when we gave the drug to patients later than 72 hours of fever onset. So other results generated from the trial from post-hoc multivariate analysis are that dengue virus serotype 2 infected patients were more likely to develop DHF and also high circulating NS1 or high levels of liver enzyme, AST and ALT on admission were also associated with DHF development. So in terms of the safety, the number of adverse events did not differ significantly between groups. There were symptoms and signs of dengue, and they're not considered to be ivermectin related. And elevated liver enzymes were also common, but not considered related to ivermectin. And further analysis show that ivermectin did not worsen elevated liver enzymes or thrombocytopenia or leukopenia in the patients. And these actually are common abnormal laboratory findings in dengue. So in conclusion, although primary outcome for both phase 2 and 3 were not met, some outcomes from the studies actually was interesting and were encouraging. 3-day course of once daily dose 400 microgram per kilogram oral ivermectin treatment was safe and had significant efficacy on acceleration of NS1 clearance in patients and reduced the number of cases with detectable NS1 at discharge. Although we do not see the effect of the drug on viremia levels. So one possible explanation is that plasma viral load may not be truly represent dengue virus burden in patients. Maybe detection, we use RT-PCR, which detect viral genome copies in the blood circulation, which may not really represent or directly correlate with active number of infectious viruses produced in the infected cells, and thus may not really represent our replication stage or tissue virus burden in an infected host. We also were in the process of analyzing actually the post-hoc analysis of this trial for PK/PD analysis by our collaborator at Oxford, Mahidol in Oxford, suggested that increasing ivermectin dose and taking the drug more earlier, for example, within 24 or 48 hours of fever onset would have better efficacy. So in terms of like the NS1, that the drug reduce or accelerate NS1 clearance, actually it's quite interesting. And we know that NS1 is a cofactor for viral replication and could exhibit also host immune evasion function. The protein can trigger cytokine release and endothelial cell hyperpermeability, which can contribute to vascular leak. So also NS1 is also known to be highly immunogenic, including inducing an amnestic antibody response following, especially following secondary infection. And NS1 immune complex shown in vitro to activate complement, leading to anaphylactoxin C3A5A generation, and actually these complement activation products have been demonstrated to be higher in DHF versus DF, and in fact the peak of these complement activation correlates with the peak of critical period, the time of critical period shock and leakage occur. So and it has been shown that high NS1 levels in the blood correlates with dengue disease severity. So with all of this, and but the fact that in the trial show that ivermectin, although accelerated NS1 clearance, but did not translate into clinical efficacy. So it raised the question on that NS1 might not be the only important pathogenic factor in clinical or disease pathogenesis, and also direct role for NS1 to induce vascular leak, which pretty much been shown in vitro and also in animal model in mice. Remains to be proven in humans. Another possibilities that of this discordant finding between significant shorter NS1 clearance without significant clinical benefit could be because of the small sample size. For a large heterogeneous population that we recruit in our study, both primary, secondary infections, and all 4 dengue serotypes, and also the onset of illness varying from first day to more than 3 days. And it could be that insufficient ivermectin dosage would also explain this. So another study that we have been conducting is an open label sequential dose escalating clinical trial to study pharmacokinetics and pharmacodynamics of ivermectin in children infected with dengue viruses. So we enrolled 24 children with dengue infection who have fever less than 72 hours to receive ivermectin 2 doses. The first one is lower dose, 400 microgram per kilogram, and the other one, the other 2 groups, 600 microgram per kilogram once daily for 3 days, just similar to the adult trial. And we subgroup children also by body weight. The first 6 patients were the patients who weighed more than 30 kilogram children. And the second would be the smaller children who weighed between 15 to 30 kilogram. And the primary objective for this trial are to determine PK, PD of ivermectin, and then by assessing level of ivermectin in the plasma of patients, and also correlation of ivermectin level with viral load or NS1 antigenemia. And another important outcome is to determine safety of ivermectin in treating children with dengue infection. So far, the current status of the trial, patient recruitment is completed, and data analysis and PK/PD modeling is in progress by our collaborator, Professor Joe Tarning and Nicholas White at Mahidol, Oxford University. Mahidol, Oxford, yeah. Another actually interesting observation from this study was that NS1 clearance was shorter compared to viremia clearance, and median NS1 clearance time in placebo was 96 hours, but was accelerated to be 1 day faster in the ivermectin group. And noticeably, as administration of ivermectin start to see the effect in NS1 levels after the second dose of ivermectin administration, as pointed out here by an arrow. So we are very curious to see this result, and we think that ivermectin may have some other additional effect on NS1 independent of inhibiting virus replication through NS3 and NS5 inhibition. So because liver is the main target organ for dengue virus replication in humans, we have used our recently developed in vitro human stem cell derived liver cell model, which have been shown to have similar characteristics to primary human hepatocytes, and was shown to be very efficiently supporting dengue virus replication compared to most commonly used cells like HA7 or HepG2 cells. And we are currently using these cells to further investigate anti-dengue mechanisms of ivermectin, and as well as other repurposed drugs. So we actually started testing ivermectin in dengue virus infection in our hepatocyte model here, and we started with the local strain of dengue 2, and that's the EC50 to inhibit virus production and NS1 secretion. And actually, we are in the process of testing the drug with the most recent clinical isolates from our patients in the hospital cohorts. And we also did detailed kinetics experiments, and the results, preliminary results, reveal that ivermectin, actually in this experiment, we do side-by-side ivermectin and ribavirin, which target at different, so this is ribavirin directly target replication, but ivermectin also target replication, but we suspect that it may do some other things as well. So you can see here that ivermectin seems to have stronger inhibition at the very later time point compared to the ribavirin in terms of the virus production and as well as an S1 secretion. And we are in the process of analyzing data using proteomic and transcriptomic approaches. And the preliminary data reviewed significant upregulation of host protein involving immune response and downregulation of host protein associated with viral production. And preliminary data from cytokine measurement also showed effects of ivermectin on cytokine production, which are, in the opposites of the dengue virus infection. So apart from ivermectin, a set of repurposed drugs are in the pipeline, and we are currently performing in vitro testing or screening the select-based combination to further test in vivo and in clinical trials. Our best strategy would be first conduct PK/PD study for selected drugs or drug combination to actually confirm antiviral efficacy before investing for a large efficacy trial. And while drug repositioning actually supposed to accelerate the pathway for drug discovery and therapeutics discovery for dengue, we also in parallel in the process of developing controlled human infection model to be able to use as a platform for testing antivirals and as well as vaccines candidates in Thailand. So this is the acknowledgement slide for the ISNTD trial. So we have so many collaborators from in the country. The trial was done in Synergies Hospital here, and in our another hospital in Northeast Thailand. And we got funding from several funding from Department of Disease Control, Ministry of Health, and Thailand Research Fund and Mahidol University. And we also got support from placebo and drug ivermectin medication from Atlantic Pharmaceutical Company in Thailand. For the PK trial, the PK/PD study, we also get help from Mahidol and Oxford Research Unit. And we got funding from Thai funding from HSRI and Faculty of Medicine Synergies Hospital. And these are actually the pictures of our team, Dengue Therapeutics, and our collaborators. And that I will end my talk here. And thank you all for listening.